if we say you're not a candidate for LASIK, you might find that you're a candidate for ICL, and ICL is a fantastic procedure. We're doing a lot more of them. I think globally a lot more are happening as well, because it's a great option where we're not removing tissue as well. So there's definitely some advantages as well. So I think be open-minded and yeah, and just take the plunge.
More and more people are hearing about LASIK as a fast, reliable, and exciting option for reducing their dependence on glasses and contact lenses. But not everyone knows who is actually suitable and what factors LASIK clinics look at before giving the green light. In this video, we'll break down the core eligibility criteria for LASIK, the reasons some people may be better suited to alternative vision procedures, and what patients should expect during an initial optometrist assessment versus a pre-surgery surgeon's consultation. Once again, I'm joined by Dr. Erica Darian-Smith from Eagle Eye Surgeons. Erica is a leading corneal and refractive surgeon in Sydney, treating patients from Mossman to Penrith with procedures ranging from LASIK to lens exchange surgery. But first, who am I? My name is Paul Salloway. I'm the owner of Optics Digital. We're an agency that helps eye care professionals to grow their practice. So to get started, so for people considering LASIK, what makes a cornea suitable or unsuitable? And what do people often misunderstand about this?
Yeah, sure. So as part of the initial workup and as actually part of the free assessment, we do imaging of the cornea. So we have a number of different devices. So we have the Pentacam, which is a corneal tomographer, and that basically looks at the corneal shape across 4 different maps. And it also has a score, which is like a risk score called an ectasia score for will the cornea become unstable once we remove tissue with the laser. And then we're also really lucky to have an MS39. So that's an Italian-made device, which also gives another perspective on the cornea. So we use it in conjunction with the Pentacam, lots of information about the cornea. And that would include things like the corneal thickness. So in really thin corneas, you may not be suitable for laser eye surgery, or you may be a better candidate for PRK as opposed to LASIK or SMILE. We look at the shape of the cornea. So we want to make sure that it's not kind of like this, like a cone shaped, which you might see in a keratoconic eye. And we see that on a number of different scans, because that would be a contraindication to having laser surgery. And then we look at if the cornea is dry. So we look at the surface of the cornea to see what the tear film's like. And the MS39 has a really neat function where we can actually map the tear film. And then, yeah, we look at all these things together, including the stability of the script, to see if you're suitable for laser. And depending on different things, we might push you more towards a PRK option over a LASIK or an ICL, sorry, LASIK or a SMILE option. And then if you're not a laser candidate, then we might look at doing an implantable Collamer lens, which is essentially putting a contact lens inside the eye. So it's intraocular surgery.
So there's a whole alphabet soup of different procedures that Eagle Eye surgeons can offer people who are looking for vision correction. We probably won't have time to go into detail about all of them.
Basically offer everything. So patients know when they're coming here, they have the whole range of procedures. And then we basically pick 1 or 2 that are best suited for your eyes. So you might have a few options, or you might just have 1 option, depending on all those factors I just mentioned. And then there's also other factors, but they were the corneal factors that we were talking about.
So is it common for people to be surprised that LASIK isn't suitable for them? I mean, they come to you and maybe their heart's set on LASIK, and then they find out that perhaps a different type of procedure is better for them. Is that a common thing?
Obviously, it can be disappointing if you're coming in and your expectations are that you're going to have LASIK, but lots of people don't actually know about all the other options. So lots of my patients don't actually know about SMILE, which is a great option if you've got dry eyes, or if you're martial arts or a very heavy sports player because you don't have a flap. We've spoken about SMILE before. And then some patients also don't know about implantable Collamer lenses or ICLs. So I think actually when they come here, even if you're not a candidate for one thing, we can usually offer you something else. It's very unusual that we can't offer you anything unless your script's not stable or you're just not suitable at all. So I think it's really exciting that we can offer different options. And at the end of the day, you just got to pick the option that's best for you. You don't want to just kind of definitely have your mindset on LASIK because that might not be the best option.
All right. Well, from an age and prescription standpoint, you mentioned prescription. So from an age and prescription standpoint, who would be an ideal LASIK patient then?
Yeah. So usually my age cutoff is I like to do 21 and over. Under 21's usually that you're still developing. So I know some people will do 18-year-olds, but I'm usually 21 and over. That's just my personal preference because I think we're still developing. And then the script has to be stable for a minimum of a year, but the longer it's stable, the better. So, if someone comes in and tells me their script hasn't changed for 5 years, I'm thinking fantastic. It's a very stable prescription. Then we have to also look at the degree of the script. So if they've got a large prescription, like they're very short-sighted or they're very long-sighted, that's obviously different to someone who has a smaller script. And that's important because people that are very short-sighted, generally it's more likely that they'll regress after laser surgery because there's just more of the tissue that we're ablating and the scripts generally aren't as stable. So they're all important factors to consider. And, if you're a really high myope or even a really moderate myope, you might be better off doing an implantable Collamer lens. So we do offer the different options for our patients. But I do think that ideally 21 and over, stable prescription for a minimum of a year. And then we are getting a lot of contact lens wearers and ortho K wearers. So this is another interesting cohort of patients, especially ortho K. So if you've been wearing ortho K since you were in your kind of late teens, and then you come in at 27 and you suddenly want laser eye surgery, we definitely need to make sure that there's been an adequate or appropriate amount of washout time because the ortho Ks will change the shape of the cornea. That's how they work. So we need to definitely give it a minimum of 2 months without the ortho Ks in. And then usually I repeat the refraction monthly for a few visits until we're sure that it's stable because we don't want to be doing laser surgery on an eye that's still changing. So I do get a lot of inquiries about laser and ortho K patients, and that's kind of the schedule that I follow. But the most important thing basically is to make sure that the cornea stopped changing shape and that the script is stable.
How about somebody who wears rigid contact lenses, like not ortho K, but just regular?
So still you need to have an appropriate washout time. Usually it's around a week per decade of use, but generally it's 2 to 4 weeks is a good idea to have the contacts out. And again, I do the same thing. We just repeat the refractions until we're happy they're stable. Soft contacts are a lot easier. They need to be out for at least 3 days. 3 to 5 days prior. But then again, if you're a heavy soft contact lens and you're wearing them from dawn to dusk, again, a longer washout period is suitable. It's very patient dependent. We get a lot of information from the refraction and from what's called epithelial mapping. So one of our scanners looks at the skin on the surface of the eye, and it gives an idea of kind of how much the contacts are impacting on the shape of the cornea as well.
Okay. And what about people in their 40s and 50s, perhaps with presbyopia? Is LASIK still an option?
Yeah, so as you know, we offer presbyond here. So that's a type of LASIK procedure for presbyopic patients, purely for people that are just presbyopic, so they've lost their near vision. Or also we can combine that if they have a refractive error as well. So, they might be long-sighted for distance and also have that loss of near vision because of an aging process. So we offer presbyond, which is a special type of LASIK on the Zeiss platform. There's different types on the market. That's just the one that we offer. We find it gives a really nice range of vision for those presbyopic patients. But again, if you're not a candidate for that, you may be a candidate for clear lens extraction. So a lot of 50 and over patients who aren't laser candidates for whatever reason, thin corneas, dry eyes, then they might be a better candidate for clear lens extraction. We do a lot of clear lens extraction here at Eagle Eyes. And it just depends again on suitability. But again, usually we can do one or the other.
Okay. Well, you mentioned dry eyes, and that's a nice segue to my next question, which is how much does the quality of the tear film matter for LASIK safety and LASIK outcomes?
I mean, it's really important because if you don't have a good quality tear film, you're not going to get good scans. You're also going to get fluctuating refractions or scripts. So when we refract you on our phoropter, which is a little machine over here,
Right.
that's the phoropter. So when you come to our clinic, you'll sit down in the chair and your refraction will be taken by the optometrist. So we find that with an unhealthy tear film, you get unstable prescriptions, fluctuating scans. So it's critical. So all our patients are on preservative-free lubricants, omega-3 supplementation. We really prime the eyes for surgery before we do the surgery.
Okay. And are there any other systemic or medical factors that matter? Like, for example, if somebody's pregnant or breastfeeding or have diabetes or something else, do those factors also come into
Yeah, so we
consideration?
have like a whole questionnaire that patients are asked when they come in, but we ask things like, do they have any autoimmune conditions? Because that can sometimes mean that you have a higher propensity for dry eye and ectasia. We ask patients if they've had any previous herpes infections in the eye or infections in general, if they've had any corneal scarring from foreign bodies or anything that might prevent us getting a clear suction for the laser or clear plane for the laser. We also want to know about their occupation. So we've touched on this before, but we want to know, as I said before, are they a mixed martial arts expert? Well, they should not be getting LASIK then. They should be having SMILE perhaps because we've got less risk of flap complications. Even surfers and things, I usually say it's probably better to have SMILE in case the surfboard, hits the eye or there's an accident. So I think occupation is really important. Overall health. Is the eye healthy? Do they have diabetes in the eye? Do they have glaucoma? If there are other problems, then generally they're not a great candidate for laser. But again, it depends on the severity of these conditions. So I think it's really important for patients to come in and have an assessment. We take a thorough history and go through all those questions. And then the same thing is done again for the clinical exam. We go through all the different parameters that I spoke about before and more in the initial assessment, and then again with the doctor consult. Specifically for pregnancy, so pregnancy itself is a complete contraindication for any kind of laser eye surgery. Breastfeeding is a little bit different. There's been various papers on it, but essentially, usually if you're 90 days postpartum, so 90 days post-pregnancy, and the script's stable, then generally it's okay. But it does vary, and again, it's a case-by-case basis, but it's a very clear cut for if you're pregnant.
Okay. Well, if you're watching on YouTube right now and you're getting value from this, can I ask you to please hit the like button? It really helps us out with the YouTube algorithm and improves the odds that other people will get benefit from this video also. All right, Erica. So you've talked about how lifestyle it plays a role in choosing what is the best option. How do people's visual expectations play a role in this as well? I mean, there may be some people who, are hoping for perfect visual outcomes, and others maybe who aren't exactly looking for that. So is that something else that you consider?
Yeah, of course. So personality definitely comes into it. So occupation and personality, and that's really touched on during our consults. We have a quite thorough consult. We need to work out what people's visual requirements are, what their expectations are from the surgery. Obviously, everyone wants perfection, but perfection is not always possible. So I think we strive for that, but patients need to have a really clear understanding of the potential risks of surgery. It's obviously really safe overall, but there are still risks to eye surgery. They need to have an understanding of what kind of vision they're going to get out of the surgery. And we discuss all of this really in depth at the consultation. But for sure, different personalities might mean that, you choose one procedure over another, but we really tailor that depending on what we've kind of brought up at the conversation.
So people in certain occupations, like pilots, for example, they might have like very high expectations.
So they might have they need to have high expectations because their license depends on it. So, they'll have very clear requirements for good distance vision. They'll need to maintain contrast sensitivity. So, yeah, we definitely take that into account. Generally, laser, as a general rule of thumb, upholds most of these requirements. It's actually a very precise type of surgery. And as does our premium cataract surgery and our clear lens extraction. But, you have to go through all the risks. So some of the multifocal lenses might have a side effect of visual aura, like glare and halos around lights, and that needs to be shown to a patient through a simulator and discussed with patients. So I think we have to tailor all the procedures based on occupation, personality, medical history, and clinical exam. So all these things together help us decide, should they have surgery? Are they a good candidate? And what surgery should they have? Because as I've said, we've got a whole host of options for our patients, which are not only age dependent, but they're also dependent on the suitability of what they do.
Yeah. You mentioned with multifocal lenses, there can be sometimes issues with light. You're talking about refractive lens exchange here?
Yeah, so refractive lens exchange or clear lens extraction,
yeah.
we're essentially removing the natural lens in the eye and replacing it with an artificial lens. And whilst those lenses are amazing and the technology continues to improve, it's important for patients to, again, have clear expectations about what they're getting from the surgery and what that lens is going to deliver for their eyes and for their occupation.
And what about LASIK? With LASIK and Presbyon and Smile, are there any issues like that with light?
So generally, contrast sensitivity is extremely good with laser. That's not usually an issue. Sometimes you can get some glare and halos around lights at nighttime. Usually that goes away with time or gets better with time. We don't really have that many patients that really report that. We're very careful here because, again, we customize for patients. So I'm very careful looking at measuring pupil size of the patients in the dark and then customizing the optical zone of my laser to compensate for that. So patients then, the treatment is essentially suitable for their pupil size. So generally we don't have many complaints about glare and halos at night time. And usually there's a neuroadaptation period anyway. So with time that gets better on its own.
Okay. All right. Well, when a patient comes to your surgery, eagle eye surgeons, they go through effectively a two-step consultation process, don't they? So first they meet with an optometrist, then they meet with the eye surgeon before they, have the day of surgery. So what does your optometrist assess during that initial consultation, and what requires a more advanced diagnostics and consultation from a surgeon?
So the optometrist will check the prescription stability. They'll look at if the patient has severe dry eye, if there's any early corneal changes or changes on the scans that are definite red flags and that, you're contraindicated for surgery, and just a general ocular health. Then when they see me, we go into the scans in more detail. We look for nuances. We also do a dilated assessment. So I have a look at the retina and the back of the eye. And we recheck the script once you're dilated, because it's important to check that the script is relatively stable even post-dilation. And then we talk about the options for the patient based on their occupation and their personality. So it's a little bit more customized. So really the initial assessment needs to see whether or not you're a candidate for laser. We still have patients that come in and they're not a candidate for laser, but then they want to go on to see me for implantable collamer lenses or ICLs. So just because you're not a candidate for laser with the optometrist assessment, it's just a screening. It's basically a screening assessment to give you a ballpark idea of what you may or may not be a candidate for. I've definitely seen patients that have seen the optometrist. The optometrist has said, you may be a candidate for Smile. And I've said, actually, I think it's better to do ICL, and vice versa. Because again, I have to emphasize it's a screening assessment, but really, the more thorough assessment is obviously done with me, which is the paid assessment. And, that's because I have to use my expertise to go through all the different factors and put it all together. I think the initial assessment is fantastic because it gives patients an idea of, oh no, so I'm not a candidate for laser. I'm not really interested in ICLs at this time. I might leave it. Or, oh, I'm not a candidate for Smile, but I actually really, that's cool. I didn't know about ICLs. Let's do that. Or I'm a candidate for Smile and I'm going to go and see the doctor now because I want to book my Smile in as soon as possible.
Right.
So it just depends. Like there's all the different scenarios, but it just gives patients also an opportunity to not feel obligated. Like they can just ask questions, get a general check of their eyes and see if they're suitable, but they don't have to feel like they have to go ahead. you know, because it's a big decision and it usually requires some thought and some time. I have lots of patients that see me and then a year later they come back and they say, I'm ready to go ahead now.
Right.
You know, it's a decision that usually takes a bit of time, and we appreciate that at Eagle Eyes. And I don't want my patients to feel rushed. I want people to go in knowing everything they need to know, ask all the questions before the surgery. We see them multiple times on different days. So we see them, usually the optometrist sees them on one day, I see them on another day, and then they have surgery on another day. So they've usually had like 2 or 3 visits before the surgery. We check the script again, day of surgery. We're pretty thorough. And I think patients really appreciate the fact that, you know, they've had a number of opportunities to see us, to ask questions. Nothing's rushed. It's a really important decision, eye surgery. I totally recognize that. We take it super seriously. And I think that's what works for us at our clinic.
You mentioned a piece of equipment before. I think you sort of call it a pentagraph. Is that right?
Pentacam.
Pentacam. Okay,
Yeah.
that's close. And I think I've heard some optometrists say to me in the past, like that's on their bucket list of, you know, of equipment that they would love to have. So I gather it's quite a, you know, advanced piece of equipment that not every suburban optometrist may necessarily have. Is that right?
So the majority of optometrists probably don't have pentacams. There are some specialized optometry clinics that may, but the majority, I can say, would not. It's very much a specialized piece of equipment, usually in an ophthalmology setting. We don't just use that for laser eye surgery. I use that for my keratoconus patients to track how they're doing with their keratoconus. After cross-linking, I use it for monitoring. So it's a very specific device, quite very high technology. We have that, but we're also lucky to have an MS-39, which I can tell you, I'm pretty sure no optometry clinic will have. So we really do have the latest technology here, and that allows us to make the best decisions for our patients and to get information from a number of different devices and average that information, because, you know, you never want to just put all your eggs in one basket. You don't want to rely on one machine. So we have a number of different devices, and then we obviously use our clinical skills. We have a number of refractive surgeons here at Eagle Eyes. We have myself, we have Dr. Lee, we have Dr. Zhang, and we've got Dr. Gulam as well. So between us, we're all highly trained. Most of us have all done fellowships. I mean, I did a fellowship in Toronto for 2 years in refractive surgery. I'm also a fellow of the World Congress of Refractive Surgery and Visual Sciences. So we have a lot of experience, and we use that to make the best decisions along with our equipment and along with our team. So kind of everything together we use to get the best results for our patients.
So that initial consultation that a patient has with your optometrist is free, I believe. Is that right?
Correct. That's right.
So given that you do have all of this advanced equipment and expertise and experience, would you say there's a good argument when somebody's looking at that initial step of whether or not they're a good candidate? Is there a good argument to say that they should be coming to a clinic like yourself at Eagle Eye rather than asking their own local optometrist, whoever that may be?
I mean, most of the time, it's still good to ask their local optometrist, because collaborative care. So it's still good to ask their local optometrist, is my script stable? Do you think my script would be suitable? Because the optometrists that refer to us really know their patients. They know their general eye health. So, you know, I get a lot of referrals from optometrists that already have listed out, you know, this patient has this script from these years. They use the contact lenses this often. They're a glaucoma suspect, but they don't currently have glaucoma. They kind of list everything out. And so I think that they're the best person to actually initially ask, but they still don't necessarily have all the information that you need to make an actual informed decision. And that's why we offer these free assessments, so the patients can do that. And there's no obligation. Like, you can come in, have all the scans for free, and then, as I said, I have plenty of patients that have seen the optometrist, and then a year later they'll come back and book in with me because they've decided now's the time financially, now's the time with their work. Like, life gets in the way, people are going away. I like my patients to be around usually for a little bit of time after the surgery, just to monitor them and make sure that everything's going well. So there's so many factors that come into play. But I think it's collaborative. Like, lots of patients that see me from out of Sydney. So I get patients from rural New South Wales. I've had a few interstate patients, which is lovely. So those patients will actually, lots of them will follow up with their optometrist. So it's really important that there's the lines of communication are open, and that we're all aware of what's going on with our patients.
Yeah. All right. Thank you. Well, Erica, so as always, it's been a really clear and informative and practical explanation of LASIK and how suitability is determined. Do you have any final words of advice for somebody who's thinking of LASIK but isn't sure if they qualify?
Look, I think the initial plunge is a bit scary, but I think we try and make that nice and easy for our patients. So you don't have to commit even to a doctor initially. You can just see our really, really highly trained optometrists, see if you're a candidate. We give you some information to go home and read. Pretty sure there's a video where I'm saying some stuff as well. So you can do all of that at home, and then when you're ready, you can come in and see the doctor and take the plunge if you're ready for it. I think it shouldn't be rushed. You should feel really comfortable with your surgeon. We're also welcome second opinions. So if you go, like, there's lots of clinics around that, also offer a similar service. And I think that it's important to feel comfortable with your surgeon, feel comfortable with the clinic and the equipment and where you're going to have the surgery. So all our patients, when they come in, they see our laser suite. They're familiar with the clinic. They've already met our staff. By the time surgery comes around, they already kind of know everyone and they feel really comfortable. And I think that's important. So that's the main things I take home. And then I think also be open-minded. If we say you're not a candidate for LASIK, you might find that you're a candidate for ICL, and ICL is a fantastic procedure. We're doing a lot more of them. I think globally, a lot more are happening as well, because it's a great option where we're not removing tissue as well. So there's definitely some advantages as well. So I think be open-minded and and just take the plunge.
Excellent. Okay, well, where can people reach you if they'd like to book an appointment or learn more about their refractive options?
Yeah, so they can go on our website, www.eagleeyesurgeons.com.au. Also, when you come to our clinic for a free assessment, you'll actually be emailed booklets depending on which procedure we think you're suitable for. So you'll get all that reading information. And then also, just if you chat to our staff and come and meet our optometrist, a lot of that we can verbalize to you in person.
Okay.
And also our YouTube channel.
Yes, don't forget the YouTube channel. So once again,
and our Instagram.
Yes, and Instagram and Facebook.
Clearly said from someone who does a lot of social media stuff.
And speaking of which, if you like this video, if you got value from it, once again, please hit the like button. That really helps us out with the content. All right. Well, thanks so much, Erica.
Paul, it's been a pleasure. I'll see you soon.
Thanks everyone for watching. Take care, and we'll see you next time. Bye for now.